these are the three big areas that are suggested for non-pharmacologic control of blood pressure: weight management, diet, and exercise. And by far, the element here that has the greatest impact on somebody being able to lower their blood pressure is weight control. Big effects here, and really pretty modest amounts of weight loss will lead to large changes in blood pressure. Now, over time, the blood pressure starts to rise a little bit, but it never goes back to what it was before the weight loss. But if somebody loses, say, 5 pounds, 15 pounds, in a 6-month period, their blood pressure is almost always quite a bit lower at 6 months. If they maintain that weight loss, it might creep up a little bit in the next 6 months, and then it stabilizes. But it doesn't go back to where it was before. And so pretty small reductions in weight often result in clinically significant drop in blood pressure. With fairly modest, it's considered usually 10 pounds or 15 pounds. And I realize that's different if you're talking about a small statured person who starts out weighing 130 versus a large statured person who starts out at 300. But really, you don't need to lose large amounts of weight to have an effect on blood pressure. And this is an old table, but I keep it in here. It's from the Joint 7 Task Force report. Now the Joint 8 is out on blood pressure control. And weight reduction, you can see that reducing weight in a wide variety of studies, and these are actually meta-analyses, so there's many studies associated with this. So this was looking at a 22-pound weight loss, a 5 to 20 millimeters of mercury drop in blood pressure, and a 20 millimeter drop in blood pressure. That's what you expect to see giving 2 antihypertensive drugs. So you can get pretty substantial. And of course, all of these weight control, diet, and exercise, it gets to patient compliance. And once again, compliance means yielding to pressure, and the pressure here is living well for your body to do better. And that gets to be an issue. Diet, there's a number of things known now in the diet, and you're having a nutrition course now, right? And so you know more about this than I do, but I always talk about the DASH diet plan. It's really more of just a way of, it's eating habits rather than a diet. DASH goes back many years. Going back close to 20 years ago were the first studies on it, and it stands for, but those were preliminary studies, and then about 10-12 years ago they started doing the DASH studies, and DASH stands for Dietary Approaches to Stop Hypertension. And so what the DASH diet really is, it's simply a diet that's rich in fruits and vegetables. It's lower in red meat and animal fat. It is not vegetarian at all, but it is lower in red meat. And that means there's a high consumption of potassium, calcium, magnesium, and also arginine and nitrate. Turns out those are important. And there is a reduction in sodium intake. And so a lot more fruits and vegetables, 8 to 10 fruits and vegetables a day minimally, decreased red meat, decreased sweets, decreased saturated fat, low fat dairy products, and nuts. And what if one follows this diet? That means for most people their consumption of potassium, calcium, magnesium, arginine go up quite a bit. Now, I really have a problem with, if you were in my biochemistry course and my other physiology course, you would see about 10 times throughout an academic year where I show, let me show you this study on supplements. And I really have a problem with how supplements, you know, supplement companies, it is to their benefit that quality research isn't done. It's to their benefit. And that goes against, because they can make one claim, and with all supplement claims, there's at least one kernel of truth, but it's just been extrapolated. Interestingly, you can give potassium as a supplement. You will drop blood pressure about 2 to 3 millimeters. You can supplement with calcium, drop 1 to 2 millimeters. You can supplement with magnesium, 3 to 4 millimeters of pressure. Arginine, you can drop about 4. But when you consume the same amounts of these nutrients from whole foods and not as some capsule, blood pressure will drop about 15 to 20. So what this tells me is, number one, there's possibly these work together, if not in synergy, but at least with additive effects. And there are other micronutrients in food that we just haven't identified yet that are also beneficial. So I'm a big proponent. Try to get people to not think about supplements, think about how to eat healthier foods, because time after time after time, that shows to be far more efficacious. So here was somebody, the group that they just remained on their usual diet. Here were the people that went on the DASH diet but without the low-fat dairy products, and this is with the low-fat dairy product. Well, the DASH diet plus the low-fat dairy products, and that's for systolic, this is for diastolic. And those are some meaningful, and actually this was the low effector arm. There's another thing that they did, and it dropped down to 15. So if you might have already run across this or seen it in one of your textbooks, the DASH eating plan, it's not a diet. It is just a way of choosing foods to help manage hypertension. Exercise has a very important role for managing blood pressure. It isn't as great of a blood pressure reducer as weight reduction, but it is quite a bit. With regular exercise, most people will see a 4 to 9 millimeter mercury drop in blood pressure, and really what it is 30 minutes most days of the week. There are both acute and chronic blood pressure lowering effects. After one exercises, there is a 2 to 6 hour period of post-exercise hypotension. And that's if you're using large muscle groups. It's not surprising, because when you are exercising, what are those exercising muscles producing? Local vasodilating mediators. So that increases blood flow to that muscle during exercise, but you don't just immediately stop producing those mediators once you stop exercising. Why? You need to have increased blood flow following exercise to help support post-exercise recovery. And because of that continuing production of local vasodilating mediators, you have a period of post-exercise hypotension. So that's the acute effect. So if people are exercising like 4 times a week, you kind of put those acute effects on one another. Different times a day have different effects, but there is also a training effect that if one consistently exercises 4 to 5 times a week. And there's quite a bit of research out there on what type of exercise. Brisk walking is extremely effective. Brisk walking with spurts of going, say, 4 minutes fast, 3 minutes lower, 4 minutes fast, and repeat that a total of 4 or 5 times really drops blood pressure. So looking at exactly how to write a prescription. So don't go home and think you can go, Grandpa, we're going to go out and do intervals. No, don't do that. If Grandpa's used to going out for a brisk walk, you just say, way to go, Gramps. because there's other things that can happen with exercise as well. Now there's other things there's many other things, and I just wanted to throw this one out because now I'm an N of 1, but I happen to be entirely typical in many aspects of my physiology and pathophysiology. My blood pressure over the years was just creeping up, and my morning blood pressure would be about 133 over 87, something like that. So I was clearly pre-hypertensive, but never got into the hypertension zone. My wife always talked about, man, you can snore like a freight train. Well, I didn't know freight trains snore. But anyway, I can really roar like a freight train. Anyway, I decided I am just exhausted throughout the days. I'm going to ask if I can have a sleep study done. Turned out I had moderate obstructive sleep apnea, and I mean moderate. Every hour I had 18 of these hypoxic apneic periods, where some people have 50, 60. So what happens during those periods is your sympathetic nervous system turns on. And think about what that does. And you know, more hypoxic, more apneic, the more it activates. So this was going on 18 times every hour throughout the night. And so I go on APAP. It's like CPAP. So I sleep with with airflow out the nose. It keeps my airways open, and within a week, my morning blood pressure was down to 110 over 68. And my morning blood pressure has pretty much stayed there. That's dramatic. And not only that, my cholesterol went down, which wasn't bad, but it went down. My morning glucose went down. And you know, once I started thinking about it, all those things are increased if your sympathetic nervous system is activated. So there are other things, yeah.
Is there anything you can do to not have to wear a CPAP or an APAP, or like what?
Well, there's mandibular advanced devices that reposition your lower mandible, that they don't work for everybody. You know, some people end up having soft palate surgery to go in and trim out that soft palate to relieve the obstruction, because when you fall asleep it relaxes and it'll increase the resistance to airflow, and that's what leads to it. So there are surgical methods, there are oral methods, and I decided I was going to go for the gold standard. And wow, what a difference. Within a week, it was just like I was on meth. And you know, it's like, wow, what's going on? I'm not falling asleep. And I've come down a little bit, but it's just been, the last 18 months, it's just been like a new part of my life. And I wasn't bad. I wasn't bad. I was extremely moderate for this. Okay, so yeah, now there's been a number of studies where they've combined these things, and yes, controlling your weight, doing exercise, watching your diet, it's all good, and it drops your blood pressure down. Don't drink too much alcohol. Very quickly, I'm just going to show you, and you can go through the slides, how there's different classes of antihypertensive medications, and you now have the tools to understand how they work. So here's that equation. Here are those elements that, you know, what regulates stroke volume, what regulates contractility, what regulates arterial vasoconstriction. Diuretics. Diuretics are a cornerstone in managing hypertension, and what do? They decrease plasma volume, which decreases preload, which can help to drop blood pressure. Beta blockers. Diuretics and beta blockers often are prescribed first line together for controlling hypertension. So what do beta blockers do? Well, you know that they're going to block beta-1 adrenergic receptors at the SA node and at the ventricular myocyte, so they're going to decrease heart rate, decrease stroke volume right there. That's going to decrease cardiac output. They are also going to decrease the release of renin from the kidney, which leads to the production of angiotensin II, and angiotensin II is a strong vasoconstrictor. I didn't put that on your notes, but that increases total peripheral resistance. So If you give a beta blocker, you decrease the release of renin. What does that do? You decrease the release of renin, you're going to have less angiotensin 1, you'll have less angiotensin 2, so you'll have less angiotensin 2 mediated vasoconstriction. That drops total peripheral resistance. Angiotensin 2 causes the release of that aldosterone steroid hormone that causes your kidneys to retain sodium and chloride. That builds your plasma volume. If that's not happening, your plasma volume goes down, preload goes down. ACE inhibitors. ACE inhibitors are another way. These inhibit this angiotensin converting enzyme. So you give an ACE inhibitor, you decrease these aspects we just talked about. There are some people that are called high renin hypertensives, and this is the treatment of choice for the high renin hypertensive. There are angiotensin 2 receptor blockers called ARBs, which will just directly go in and block the angiotensin 2 receptor, so you decrease aldosterone release, you decrease that peripheral vasoconstriction. You can have aldosterone receptor blockers. Some of these more specific ones, they cost a lot more and they don't show any increase in effectiveness. Calcium channel blockers, you know, we're going to stop here because I didn't put any notes, but I do want to talk to you about surrogate endpoints and primary endpoints. With control of blood pressure, while you're doing that, too high of blood pressure can kill you. That's a primary endpoint to a study. Is there a change in mortality? And oftentimes, studies don't last a long period of time. You see, if this group, are there more of them still alive? Are there more of these folks dying? So you use these endpoints. Okay, this drug decreases blood pressure, so we know it's good. Well, that's a surrogate endpoint. It's easy to measure, but is it really associated with what's going on with that patient? And what you're going to see, the more you study, the more you're into this curriculum, there are certain endpoints in studies that, you know, really what you want to do is this patient less sick? Is this patient not dying? And it'd take decades